The topic today is 3 keys to aligner learning. The key of aligner learning are to acquire the ability to think, to predict, and to fix your fault. Let me move my face. And to think about diagnosis and treatment plan, and after that, you plan your clean check. When you plan your clean check, you need to have the ability to predict the tooth movement and the speed of that tooth movement. The tooth movement has to be reasonable. And also the speed of that movement should be, and will be reasonable. Otherwise, how can they move? Finally, even you have meticulous treatment plan and precise clean check plan, sometimes it still goes wrong. So if you find a mistake, how do you fix your mistake? The mistake can be clean check mistake or can be clinical practice. For example, the doctor's skill or the patient simply didn't follow the instruction, that sort of thing. And how do you fix those? I think if you can learn these 3 keys, to practice aligner become easy, and you will enjoy a lot when you practice aligner. So let's start with the first one, how to think. This is probably the most important job that we need to accomplish, is to have the right diagnosis and reasonable treatment plan. Let me give you one example. How would you fix a case like this? A young man at the age of 14 years old. And if you look at this clean check, you're probably thinking about, Chris, are you kidding me? What's the big deal to show a case like this? It looked too easy. Indeed, it's very easy. So people will pose a question mark. What's the point? But if I show you 6 years ago, this is how he looked 6 years ago when he first visited our office. So I mark 0 year. That's the first year. That's the start point when I start to look at this case. It's an anterior crossbite and debite. How would you fix this young man? And on class 3, anterior crossbite, protrusive lower lip, of course, because the anterior crossbite. What would be your treatment plan when you saw a young boy like this? On top of that, you probably will see that he has 2 impacted upper canine, labial impaction, which is on top of the lateral incisor, between the lateral incisor and central incisor. And down below, he has congenital missing, lower 5, second premolar. Does that change your plan? And besides, if you check this case, he has a severe functional shift. Every time you look at the anterior crossbite, you always need to examine whether the patient has functional shape or not. Functional shape is important for anterior crossbody. When the patient opens up, the midline is on, and once he closes halfway, that hit the right central incisor, then the mandible start to shift to the right hand side, and midline become off. And when you open, it's the midline is on. And let me show you the video. You'll be able to see when he hit the right central incisor and then shift to the right hand side. That's why the incisor edge of right central incisor has the attrition mark. That's the evidence to show you that this case has interference, functional shift. If the patient has a functional shift, pretty much tell you this case is not that difficult to fix, because the functional shift will make the situation look worse, but it is not worse. So my treatment plan was wait. So we wait 1 more year. The next year, when the patient come in, the lower E still there. So I start to plan, give my plan. I want to do 2 or 3 stage treatment. Stage number 1, S1, stage number 1. I want to take out the upper first premolar and lower deciduous teeth. But unfortunately, the upper first premolar haven't erupted yet. So what would be the most reasonable approach? Are you going to take out this baby tooth and then take out this? I don't think you needed to do at this stage. Why not just wait 1 more year until the first premolar erupt, so it will be easier for us to take out this first premolar and take out this baby E. But at least in this stage, we already have clear vision where we're going to, how we're going to fix this case. With this impaction and congenital missing, because the congenital missing, it will be better that we take out the upper first premolar to even up the tooth number. Because for Oriental, most of the case, our lip is too protrusive. So take out the upper first premolar and close that space will solve this protrusive lip. But we want to wait. We want to wait 1 more year. So 1 more year, still there, but it's pretty close. So we wait the other 1 more year. And I took this cone-beam CT, and I find out the lateral incisor, the canine is on top of the lateral incisor. The tip is almost between the central and lateral. And what would be your thought about the future of this impacted canine? Are they going to upright by themselves after I take out the first premolar? Or they will stay that way? Or you want to have a surgical exposure, and use a 3D level to bring this back, or any that sort of thing? So we wait the other 2 years until this erupt, the first premolar erupt. And did you see the canine upright by itself? That's amazing. And then it is the time to give a green light. Go. we take out the first premolar, and I hope, and we were hoping that after I take out the first premolar, and the canine will erupt into this socket, and they will erupt straight by themselves. So we take out 1, 2, 3, and that's 6 years later. And did you see that? Beautiful canine. Both impacted canine has erupted in a very good position. They are no longer impacted. Wow, that's amazing. Without the surgery, without 3D level, we just perform serial extraction, and we be able to get this result. We kind of turn the tough case into easy situation. So now we have the second stage to fix the anterior crossbar because the impacted cuspid was solved. I love it. And they are pretty straight, except he has anterior crossbar and functional shift. So to solve the functional shift and anterior crossbar, I use BT and TB. What is TB? I will show you later. This is biturbo to create a biplate to bring the upper incisor up to correct the anterior crossbar. So we're ready for the stage 2. And this is how I build this biturbo with flowable resin, and I ask the patient to exercise this tongue braid. The tongue braid will help. The exercise of this tongue braid will speed up the correction of this anterior crossbar. It's very, very effective. And you kind of invite the patient to participate in this treatment. So they play an active role in this treatment. And they love it. So I have the biplate, which I built it, and I have the patient to exercise with this tongue braid to create action and reaction, which is Newton's law number 3. Actually, the patient is practice Newton's law number 3. Can you believe it? So that's stage 2, S2. And just a couple, maybe just 2 or 3 months later, the anterior crossbar was solved. Isn't that amazing? So, without braces and without aligner, we be able to get from here to here. And it become easy case to fix. Correct anterior crossbar without braces and aligner. And now, when you look at this aligner crane check, and your conclusion will be, oh, it's ridiculously simple, easy, so easy. But think about it. That's because we have the precise diagnosis and we have the reasonable treatment plan. And now it becomes easy, fuzzy, excellent. And why? Why we can turn this tough case into easy? Because the right diagnosis and right decision that we made at the right time. First, 2 stages. The first stage, number 1, we know the impaction and congenital missing, so we decide to have a serial extraction. For the serial extraction, we pick the right time, the right decision and right time. And we know if we create enough space, which is extraction space, the impacted cuspid might be erupt in the right position. And after that, we get into the stage 2. We solve the functional shift and anterior crossbar with biturbo and tongue braid. which we are exercise. The patient and I, we both exercise the Newton's law number 3, action and reaction. And within 3 months, 2 or 3 months, we'll be able to solve the functional shift and anterior crossbar. And finally, the aligner crane check becomes so easy. So easy. Oh, let me, right here. It becomes easy. Why it become easy? Because we have stage 1 and stage 2. So listen, learn. Key number 1. Diagnosis and treatment plan is the key, of course. Without precise diagnosis and reasonable treatment plan, how can you get this easy crane check? That's why the first key of aligner learning has to be to acquire the ability to think the diagnosis and treatment plan. After you have the right diagnosis and treatment plan, and now we get into the stage 2, the next step, next level. How do you plan the crane check? When you plan the crane check, you really need to have a clear vision to predict the tooth movement and the speed of that tooth movement. Without that ability, it is hard to come up with a reasonable treatment crane check. Quite often, when people ask me, this is probably the most popular question I got asked. Hey Chris, how to write an effective crane check? Can you show me step by step? It is hard to show you step by step. But today, I'm going to try my best to show you step by step. First, you look at this case. She has midnight severe of the arch. The lower arch was skewed. Both upper and lower arch are pretty narrow. And the chip complaint was midnight off and has a severe crossbar. Of course, the conduct I had was asymmetrical. And what will be your plan? And how do you write a reasonable, a good crane check, effective crane check? And can you show me step by step how to fix this case? So, our point is how to write an effective crane check for this case. Those are the documentation for every single case we treat in our clinic. We want to have very thorough documentation to make sure we look at every aspect that we can get for this patient in order to get a precise diagnosis and to come up with reasonable treatment plan. So let me bring right here. The whole of this section, I would like to share with you the thinking process that we have when we write up this crane check. When I send it to the aligner company, I will overlay my chip complaint and my treatment plan on top of the occlusal view, this picture. So when I send it to the aligner company, they will have this photo with my treatment plan there. Why I want to do that? Because it will be easier for me to look at the photo and also know what is the treatment plan. The treatment plan for this case actually is quite easy. It's a try-non extraction. I always say try. This verb is the key. You always say try. So you give yourself a little room for error. If it won't work up, you can say, oh, I only say try. So it's very important you say try. I love to say try non-iteration first. And the way I did it in this case, I want to expand upper arch and lower arch 3 millimeter. 3 millimeter is just a estimate number. At the end, it might come up with 5 millimeter per size or 4 millimeter per size. When I say per size, it's left-hand side and right-hand side. Okay. The chip complaint is also important in this one. I will always start with the age. The age is important. It's a young patient or old patient. Crowding, midnight up, narrow mesla, close by. So those are chip complaints I'm going to solve. And now I want to show you how to write this screen check. Of course, in that screen check, you can find this treatment plan. Doctor's comment, treatment plan, chip complaint. But I would love this prescription lay over the occlusal view. So when I look at the picture, I'll be able to see my treatment plan. I don't need to go back and forth to look at those tests. And now I'm going to show you. Let me write here. So when the screen check come back a couple days later, and it was aligner, they used 66 aligner for this case. And your job is to look at is the tooth movement, is the right tooth movement, and the speed is also right. And if there is anything wrong, you have to identify the mistake. So what's wrong with this plan 1, plan number 1? Watch carefully. Plan number 1. The engineer will start to this slide, and once he got a space, and he correct this close by and midnight. What's wrong with this screen check? Remember, my treatment plan is expand the arch. Distalization is not my plan. Remember that? I didn't say I want to distalize. Why in the plan 1, suddenly I have distalization in quarter 1, and then expand? That was not my plan. So what can you do? Let me move right here. So my plan was non-iteration, expand upper and lower 3 millimeter per side. Right hand side, left hand side, both expand. I didn't say I want to distalize. So that's the mistake in that first screen check. Did you see that distalization? Did you see that space? Open up, open up, open up, because of the distalization. So that's something I didn't prescribe when I started. Let me put right here. So I told the technician, do not distalize. Early correction of anterior crossbite by expansion and IPR. Expand upper and lower in the entire treatment. I want to expand, I want to distribute to the entire treatment. So do not distalize, early correction of anterior crossbite, and expand upper and lower in the entire treatment. It took me 1 minute to do that. I look at that screen, and then immediately I recognize the mistake. I write down these 3. So the next day, when the plan 2 come back, suddenly we only need a 32 aligner. Can you imagine? From 66 And you just give 3 instructions and become 36. And it looked much nicer because that is exactly what I want. I want an expansion, both sides. I want to distribute in the entire treatment to expand the arch. 66 alignment and suddenly become cut to half. Well, it's environment friendly because we don't waste those alignment. We only need 33 for this case. Why? If you approve the plan 1, it will take you 66. So we only expand the arch. Should get the job done. And do a little bit IPR for this case. And when you look at upfront, and I want you to identify what's the period, that specific period that we correct the anterior crossbar. Because that is the period we need to raise the bar in order to correct the anterior crossbar. It happened to be from aligner 12 to aligner 27. So in this specific period, what you can do? Well, you just give an instruction that I want to put some occlusal biturbo to raise the bar. So that's the period that we correct the anterior crossbar. So what we did here is I give an instruction precisely say add occlusal attachment on 36, 46 from stage 12 to stage 27. Because that's the stage that we want to correct the anterior crossbar, and that's the stage we need to raise the bar. So when you look at occlusal surface, you'll be able to see that we have the occlusal rate, biturbo right here. But I want to be precisely from stage 12 to stage 27. And maybe you can say large occlusal attachment will be more precise. You want a little bit bigger. So after I say that, and look at how this technician reads 12, and he put on 27, and we be able to solve this problem. And we have the plan 3. Finally, it's almost done, and finally, I would love to add a little bit precise detailing. So I told the clinician IPR, which one for midnight correction and reduce break triangle. Sometimes when you line up, you see the break triangle. I really don't like the break triangle, neither do my patient. And every time when you expand the upper arch, always remember that you need to add several degree more labial root top. Because when a liner expand the arch, most likely they are tipping, not bodily expand. So I will have overcorrection right here on the upper first molar, 6 degree labial root top. So I add, so in here, right here, I add horizontal gingival bevel attachment. Why horizontal gingival bevel attachment? Let me remind you a very famous research published by Brent Larson last year, 3 years ago. I consider it's the best by far about lung extraction. And in this article, they talk about for lung extraction case, if you try to expand the upper arch, and do you know what will happen? Most likely you get tipping. The body movement is only 36%. So the treatment plan they suggest is to add buccal root top. That's why I add this buccal root top. So let me blow this up a little bit so you'll be able to understand when you use a liner to expand the motor. What you normally will see is the aligner give a push force to expand the arch from the palatal side. So the result will be obstructing with hanging down palatal cusp. And if you want prevent this tipping and get a bodily expansion, what can you do? You can add a horizontal gingival bevel attachment which provide a pushing surface to push down and to offset the expansion force. With that, you get a motor bodily expansion, not tipping. So to add this horizontal gingival bevel to provide antagonist and also to have overcorrection 6-degree buccal root top is considered a reasonable approach. So it becomes my routine. Every time I have an expansion, for this case, I expand 3 millimeter per side, which is a lot. You put it together, it's 6 millimeter for the entire arch. So based on the study, they get mostly tipping, not body movement. So why not just do overcorrection and provide a gingival bevel attachment, which is the pushing surface to push downward and upright the motor to get a bodily expansion. Very important. And let me, can you right here? So you can take a good picture about, you provide a pushing surface to counteract this expansion force. So you get a bodily expansion. And you add 6-degree buccal root top. Well, people ask me, why is 6 degree? Or that's just a guess number, a best guess. Well, if you want to add 3 or 4, that's fine. 8 or 9 is still okay. But based on my experience, I think 3-degree buccal root top should be sufficient in this case. And that would depend on, is this adult case or kid, or how many millimeter you're going to expand in that case. Think about it. I just give 3 very concise instructions, and I'll be able to drop from 66 aligner to 32 aligner. I consider that was a great investment of your time and your material. So conclusion is not important. It is the thinking process that makes a huge difference. What I try to convince you is when you write a clean check, you actually is exercise your thinking process. It's not a formula. It's how to think. The ability to think is more important than any conclusion. So let me recap. For these 3 plans, what I did first is to look at, is any spatial tooth movement which is not reasonable. For example, I didn't prescribe distalization. How come they get a distalization? So I change it. Do not distalize. Expand upper and lower in the entire treatment. And once I know when they start to correct the anterior crossbar, I'll be able to get a precise, the time period from stage 12 to stage 27 is the time period that we correct the anterior crossbar. So in this time period, I add occlusal attachment. You don't have to glue the occlusal attachment. You just prescribe. So in the attachment, they have kind of projection there. So you can open up the bar. So again, you don't have to glue the occlusal attachment. You just prescribe and alignment. Aligner have the projection. And finally, you add some overcorrection. And if you find some bright triangle or some midnight problem, you can prescribe the IPI in the precise area. So I only use 3 plane. I just correct 3 plane. Every plane, it took me 1 minute. So 3 plane equal to ridiculously 3 minutes. The whole time that I spend in this case to write this clean check is only 3 minutes. And 3 minutes is my average time to spend in every case when I write down my clean check. And people will say, are you kidding me? Chris, how could that possible? Well, if you follow my instruction, pretty soon you will realize it is possible to write a clean check in 3 minutes. 3 plane. 3 plane. 3 plane, probably my maximum. Most of my case, I only have 1 or 2 plane done. If you know how to give a precise instruction, the rest is easy. Thinking process, one more exercise. My dear friend, how would you fix this young lady? Watch carefully. She has a 2 very, very deep impaction, anterior crossbody, which is quite popular in Asia. Asia has a lot of anterior crossbody, class 3. And in my office, we have a lot of impaction in my office. I don't know why, maybe I have too many friends. They just want to send those difficult impaction to my office to make me suffer, maybe. I don't know. But anyway, they are my friend. Step by step. How do you fix this case? First and foremost, you need to have a reasonable treatment plan. Severe clouding with protrusive lower lip. We were thinking about 4-by extraction. If you want a 4-by extraction, why not do 2 low first premolar to relieve the clouding, and on the top, you just take out the impacted canine. You're done. So our plan is extract the upper impacted canine and lower first molar, first premolar, to relieve the clouding to solve the protrusive lip. Let me get this way. So I zoom in, and then to look at this case. And finally, I settle in this picture. Because this section, I can see my treatment plan, and I can see her chip complaint. And I also, if I want to take out teeth, I will make a close right here. So it's easy for me to see my treatment plan. And that treatment plan will mirror this clean check. So I look at the plan 1, and my dear friend, would you tell me what's wrong with this plan 1? Is that reasonable to have 70 aligner to fix this problem? Why we need retract the upper incisor in the early stage? So my plan 1, my comment was do not retract upper incisor. Instead, flare out upper incisor. Because you want to correct the anterior crossbody. Why you want to retract the upper incisor? Instead, I want to flare out the upper incisor to correct the anterior crossbody as soon as possible. So with that simple, concise instruction, The next day, the plain one will look like this. They didn't recheck the upper incisor. Instead, they frayed the upper. That's good. That's my instruction. Hey, good. And then they recheck the lower. And we're done. And immediately, we can drop down the aligner from 70 to 51. And unfortunately, I see this big overjet. Is that overcorrection? No, I don't think that's overcorrection. That's way too much. So let's look at the occlusal view. Instead of retract, we fray the upper incisor, we correct the midline, and it looked pretty good. Except there are two issues that I didn't like it in plan 1, plan 2. Number one is they create too much overjet. I don't like that too much overjet, although somebody might think that's overcorrection from anterior crossbar, but it's still too much. And the number two, the midline is not up. So I would love the technician to correct this anterior crossbar and correct the midline. How to correct? If you know how to correct, then you can just give a precise prescription. But at that time, I only tell my technician, midline, need arm, reduce overjet to 1 millimeter. Did you see how concise my statement? My statement is only midline, arm, reduce overjet to 1 millimeter. 1 millimeter is my overcorrection. I don't want it 2 or 3 millimeter. So midline arm, reduce overjet to 1 millimeter. And in this case, we also have the occlusal attachment built up like this to correct the anterior crossbar. So that occlusal attachment, you cannot give that instruction before the crane check. You can only give after the plan 1 or plan 2, you know which period they correct the anterior crossbar. And suddenly, from 70 aligner, we drop to 49. And look at carefully. Did they follow your instruction to make the midline arm and reduce the overjet to 1 millimeter? The answer is yes. They did exact like that. Why can they do that? Because you give a precise instruction. Do not just say, oh, I want an ideal occlusion, I want to follow the 6 key to normal occlusion, I want to follow the AB or CRE score 0. They don't know. And it's too vague, too big. So just give very precise and very short comment. And you'll be able to get a similar result like this. It is a syncing process. Look at that plan 2 and plan 3. Huge difference. Now, with this plan 3, you know you can just hit approve and you're done. So lesson learned. Maybe I get this. Lesson learned. Prediction in crane check is the key. Of course, it's the key. If you cannot predict the tooth movement and tooth movement speed, how can you write a reasonable crane check? It's impossible to write that right crane check, reasonable crane check, effective crane check. So now, let me give you one more example. How to predict the tooth movement. Different tooth movement require different mechanics. I want you to understand that. And what is your treatment for this adult patient, 38 years old? And watch carefully. This young man has horizontal impact second molar. On top of that, he has a third molar. And the common sense will tell you that a liner is good for pushing. A liner may not be good for pulling. So any uprighting, forced eruption could be quite difficult for a liner. Could be. In my hand, it could be. Maybe in your hand, it's easy, I don't know. But common sense will tell you to upright this second molar is difficult. So what can you do? Oh, easy. I refer to the oral surgeon to take out the impact 7. Well, if you do that, let me remind you. Most of the horizontal impact second molar in this situation, the root is entangled with the nerve. If the oral surgeon take out this one, they might tear the nerve. And when they tear the nerve, the patient cannot kiss, and they don't like it. As a matter of fact, 6 years ago in the United States, they have a case. Take out this one, and turn out the nerve got numb. So the patient sued the doctor, and they lost $2 million US. If I have $2 million US, I want to keep in my pocket. So I don't want my oral surgeon and myself run into this risk. So instead, I want to take out the 8, and I want to upright the 7. Chris, are you out of mind? How can you upright the second molar? This is 7. Oh, that is not 8, that is 7. Just 11 months in treatment. And the beauty is, I can upright this horizontal impact 7. At the same time, I have the patient wear this aligner at the same time. So look at carefully. Just 11 months in treatment, we be able to upright this severe second molar without damaging the nerve. And remember, aligner is pushing. But how can you upright this? Upright this horizontal impact, you need pulling mechanic. And screw is good for pulling mechanic to provide a moment to upright. So screw equal to pulling. So why not put a screw behind this second molar and provide a pulling mechanic, and it becomes easy. So I think screw and aligner, pulling and pushing mechanic are perfect companion. You put them together, you can solve a lot of problems. If they can make your mechanic complete, why not marry the screw with this aligner? That would make things so easy for this case. How? Let me show you the detailed procedure because I want to show you step by step. First, take out the egg. So we take out the egg. It's easy because it's superficial. When you take out the egg, most likely they have a bone between 8 and 7. So you do need trim bone and surgical exposure. Otherwise, it will be difficult for you to resolve this bone. So to resolve the bone, I use osteopert to grind that up. After I grind that up, remember, this guy is a adult patient, so I always perform subluxation because I want to rule out ankylosis with elevator. So in order to provide a counterclockwise moment, which is a pulling mechanic, probably the best way is to give an anchorage behind this object and use this bondable eyelid and power chain. And the how can you put this power chain into this bondable eyelid? I have a special tie called Chris tie. The reason why it's a Chris tie is because a guy called Chris who come up with this idea, and people ask me, hey, what kind of tie is that? I don't know. I just think that's a reasonable. They gotta have a special name. And finally I said, oh, it's a Chris tie. Okay, Chris tie. But that was just easy to have a dental floss connect It's easy to get into this hole, hold the hole right here, and it's just like this. The video will show you the detail. It's so easy. It's when you look at the video, it's easy, but it's difficult for me to say because I have a language problem. English is difficult. So I put this ribbon school, which is 2 by 12. You have to have a longer school because this area covered with very thick soft tissue, which is a lot of mucosa right here. So you want to have this longer school. Otherwise, after you insert, you couldn't find the school head because the interphalangeal muscle is right here, and on top of that, you have thick mucosa. So I really suggest you to get a little bit longer, which is 2 by 14. And I wanted 2 millimeter because this area is very dense cortical bone right here. So you want the screw as strong as possible, and 2 millimeter diameter can get the job done. And I always do manual insert. I don't want to use low speed because low speed will entangle the soft tissue. So I hook out this power chain, and that provide perfect counterclockwise movement, which is pulling mechanic to upright this horizontal motor. 1 month later, I stretch this power chain and cut the extra. And 1 month later, I stretch again and activate. And this is how I take the third motor out, and that's the way I bang the eyelid, and hook out this power chain. And I also grind the bone. So let me show you the video. It will be easy for you to understand. First, you make an indentation with a probe. Oh, by the way, before you do that, you need to get local anesthesia, which is infiltration. Get the tissue numb first. And then you follow the indentation and you stabilize the mandible, which is you use your hand to stabilize the mandible and insert this mini screw. And you just keep screwing because this screw is very sharp and very strong. So once they have an indentation, you just follow the indentation. The screw tip is sharp to follow that, and you're done. Whoa! And it just took me 20 seconds. And you can adjust a little bit if you want to make a little bit deeper. Sometimes you also need to check the occlusion. If they hit the upper second molar, you might want to raise the bar or make it deeper and deeper, or raise the bar in other side with glass ionomer cement. And now you hook out this power chain. Oh, so easy. And you cut the extra. And the next month, you will stretch this power chain and you cut the extra again. And a month later, you do the same. Very easy procedure. Can you imagine? This is a difficult situation. And we are using a very, very simple. And people will ask, what is the failure rate for this Raymond school? Only 5%. We performed a study a couple of years ago. How many years ago? Many years ago. And it was just only 5%. That's it. And in this article, I would strongly suggest you free download this article, and you study. And every single step can be found here. Or you can go to my YouTube. Just type Christian also. You'll be able to see all the slides that I present in this topic. Besides, 2 years ago, seminars in orthodontics invited me to submit an article to describe the Raymond School. They wanted me to describe in detail. That's why this article took 19 pages. Have you ever heard 19 pages? Just describe a Raymond School, how to solve this horizontal impacted. This is even deeper, very deep. We'll be able to use this Raymond School. Oh, Raymond School is so powerful in this kind of situation. One more thing. This is before the surgery. And this immediately after the surgery. What did you see? Did you see the space right here is quite different from here? They have a space right here, small space underneath. Did you see that? And why? Because in adult patient, I do want to remind you, adult patient, 38 years old, there is a chance for ankylosis. So I always perform subluxation with this elevator to make sure I loosen that up. If they have ankylosis, I would even make it even loose. And then once you get it loose, you hook out this power chain, immediately you will upright maybe 10 degrees of this second molar. That's why you see this small space underneath. Those are very small details. When you listen to the lecture, I hope you pay attention, 100% attention to that. Not every speaker will tell you those detailed procedures, but I hope when I have a chance to give a lecture, I can show you every single detail. For this case, subluxation for adult patient is a must. You have to do that to protect yourself. To protect yourself. And to speed up the treatment. And if you have this plan, then the Invisalign treatment plan is easy. Extract 4A, which is in 4-7 position. This is 4A. So it's just cross right this one. So the aligner will not cover this one. Align and rounding of the arches. That's it. This is an easy case because it's a minor clouding the arch skew. That's it. The difficult part is the horizontal impaction. And with that, to upright the impact, take low 7, aligner, at the same time, we have uprighting, impacting, second molar, and aligner. The same time. That's the beauty of it. That is the beauty. Look at this picture. We have the attachment right here. That means the patient was wearing the aligner. At the same time, we have the Raymond School 2x14 stainless steel. H mean hole. We have a hole right here in case you need a 3D level up. And I put the bondable eyelid right here. And later on, when I upright it, I bond the other. When it come up into the oral cavity, I bond the other button. At first, if it's thick, you cannot bond the button. It's not easy to bond the button. Bond the eyelid will be easier because you have a handle right here. And now it's ready for refinement because the second molar already erupt. And how many aligner we use? We only use 29. Just 29. We solve the anterior clouding and the arch problem. We solve the posterior. Lesson learned. Mechanic in clean check is the key. When you write in a clean check, if you have the right diagnosis and reasonable treatment, the next is think about mechanic. What kind of mechanic will drive the teeth to the position you want? Will drive the teeth in a fashion, in a speed that is reasonable. That needs experience. And do you really think that technician has that kind of experience? No, we also don't have that experience. Why not borrow that experience we already have and put into the clean check? We are the one who has the control of that clean check, not clinician. One more mechanic. Remember I talked about Brent Larson? I love this article. He talked about second molar. It's very difficult to fix. Why? Because second molar is at the end of the arch. At the end of the arch for the aligner, it's very difficult to produce any tooth movement. Let me give you one example. How would you fix this? About 50-degree rotation, second motor. And besides, right here, good. Rotation in the last tooth require pulling mechanic, which is hard for aligner. And on top of that, the crown is very, very short. Can you see? The gingiva is right here, so the crown is very short. If you have the crown is very short, the aligner is very difficult to grab this crown. And you have the last tooth in this aligner and make the situation even worse. That's why this situation will be very difficult for aligner only. You have to come up with something different. Otherwise, it will take you forever to solve this one, unless you just pretend you didn't see it. But unfortunately, the patient recognized the problem because this is a refer case. The dentist already said, you have a rotation, you better rotate this one, otherwise there's no occlusion right there. So what I did is, we already know the school provides pulling mechanic. So what I did is I have several braces right here, sectional braces, to line up the teeth, and to rotate and to disalign, I use this button, lingo button, hook out the power chain to Raymond's screw, and that will produce a moment to rotate. So, just 5 months in treatment, did you see? 6 months. This pre-aligner orthodontic treatment, which is several braces, make it easy. We kind of turn the top case into easy. Make top case, make easy, that sort of thing. In other words, just 1, 2, 3 braces and button and mini screw. And we be able to derotate and make this top case into an easy situation. And 7 months in treatment, we're done. Did you see that when we rotated? The Y end poke out because used to be it's rotated, and now we can just, now it's ready to debunk these braces. Oh, I love this pre-aligner also. Just put several braces with this mini screw. And you provide a moment. And this moment can rotate the last tooth in the arch. Very difficult. Rotate 50 degrees in 7 months. Pre-aligner also make it so easy. So when you have the situation like this, it becomes easy for the aligner. But if you want to use aligner only to rotate and dislike this one, it could be very difficult because the crown is short because it's the last tooth. And some people will say, wait a minute, Chris, are you kidding me? We are aligner doctor. We don't want to braces. We don't want to fix the price. Well, if the 3 braces and button can make the situation much easier to treat, why not do that? Why people want to insist they only want to use aligner? Well, one thing I learned is, if the people, they insist, I only want to use aligner, I don't want to use anything else, no matter how good they are, I think those doctor has a little bit problem right here. So my suggestion to you is never, ever learn from OCD doctors. We have a lot of speakers, they are OCD, they have a tendency. Can you tell I am normal? I am very normal. But not every speaker are as normal as I am. But I'm pretty sure I'm normal. Oh, never, ever learn from OCD. Especially those people, we are aligner doctor. Oh, my dear friend. You just put several braces you'll be able to get this case like this. Why people want to insist they are a aligner doctor? I really don't understand. I really don't understand. And one thing I have to remind you, when you take this course, you are learning aligner. But I have to tell you, aligner is just a weapon, just a tool to straighten the teeth. So you not only learn aligner, you are learn the whole picture, the whole orthodontic. So in other words, the orthodontic IQ is not equal to aligner IQ. Do not come to the meeting and say, I only want to learn aligner, I don't want to learn anything else. No. You come to the meeting to learn orthodontic mechanic. And aligner is the weapon to execute that mechanic. If aligner cannot produce that mechanic, most likely they cannot fix that problem. You have to borrow other weapon. So orthodontic IQ is much bigger than aligner IQ. Please be a reasonable person. I don't want my friend to become OCD, obsessive compulsive disorder doctor. Mechanic is the key, for sure. That's why I have great respect to my grandpa, Charlie Burstone. Charlie Burstone is the one who put all the mechanic principle into the textbook back to 1962, which Christian was -1 years old, -1. I was born 1961. Oh, I love this Charlie Burstone. That's why when Charlie Burstone passed away, 2013, I decided to make this beautiful statue to remember my Charlie Burstone, my grandpa. Oh, I love my grandpa. He is very smart. He is funny. I enjoy every moment I spend with Charlie Burstone. I met Charlie Burstone when I was 27 years old. Can you imagine? And it was a Charlie Burstone inspired me to learn biomechanics. And it was a Charlie Burstone who inspired me to decide to study in Indiana University with my mentor, Gene Roberts. And Gene Roberts was Charlie Burstone's first student in Connecticut after he moved from Indiana to Connecticut. And all the mechanics he set up is in the Indiana University. That's why I love to get education in Indiana University. IU. Okay, go back to prediction. And once you understand the mechanic, if anything goes wrong, you'll be able to fix that because you know the mechanic. For example, this severe crowd, I want to take out this incisor. You want to take out the incisor? Only one incisor? Yeah. And when you take out the incisor, the next thing you probably recognize is when you use aligner to close this incisor, the incisor is very small. And the potential problem is it's hard to get root parallelism. So in order to overcome this situation, I strongly suggest to use vertical attachment for this small guy. In other words, the tip for attachment is you are changing the shape of the tooth with this attachment. And if you want to move the root become parallel, you use vertical attachment. You change the shape of the root with this attachment, like this. Right here, it will be easier for you to get a root parallel. And for the plug-in lateral incisor, sometimes it's difficult to get out. Once you get out, you sometimes get obstructing or the root torque is not enough, so you need to prescribe more labial root torque, that sort of thing. But attachment is also important. In this case, probably horizontal attachment is easier. It is the right way to get the root out. But unfortunately, it's difficult to put a horizontal. That's why I prescribe. Because when they are plugged in, it's hard to put horizontal, so I put vertical. And finally, it gets obstructing. So how to deal with this obstructing of lateral incisor, which happen quite often? First, you need to know why that happened. A lot of situation, the obstruction is due to not enough space for that particular lateral incisor to move out. And once that happens, and you need to find an easy fix using button and plus elastic, or you just refine, you scan and refine it. Most of the time, I will just refine it. But for this particular situation, it's easy. I just bound to button, lingo, and labia I use clear, and I cut it by myself and run this chin mark and get it erupt right here. Because to extrude the lateral incisor sometimes is a little bit difficult. And with the right vertical attachment for the incisor, finally we be able to get this result. And watch carefully. I want you to watch carefully. Look at that beautiful root parallel. Without this vertical attachment, I would say it will be very difficult to achieve this root parallel because the incisor is too small. The attachment is to change the shape of the incisor. And vertical attachment is to help you to do root movement. So you needed to know when to put the attachment, and you needed to know what kind of attachment is more appropriate. Lesson learned. Key number 3B. Attachment design is based on mechanics. If you are in this mechanic, you design this attachment. So when the technician give you the attachment design, you have to think biomechanics. Use your mechanic knowledge to say, is that reasonable to get this tooth movement? And at the end, you'll be able to get this result. The mina is not on because we have a single incisor extraction. But overall, the occlusion is good. The line-up is good. The profile is good. And the patient is happy. And happy also is a good also. Wow, that is the bottom line. You need to get the patient happy. If the patient is happy, I am happy. Most importantly, my wife is happy. If my wife is not happy, I have trouble. Good. I love it. So I decided to publish this article in Journal of Digital Orthodontics. So you can free download JDO at ijdo.pro. This is my website. You'll be able to find this article for free. All the article I publish, I want over my friend for free. I don't want you waste your money. And the beauty for this article is every single detail about this treatment can be found in this article. We talk about the attachment design, why we want to design this way. We also show you if you have the obstructing, how to solve the mistake, the problem you find during the treatment, like this. I put a button and I cut it. Every single detail, even how I make the IPR, how I do the gingivectomy and frenectomy, every single detail. And at the end, I will attach this DI and CIE, and the CIE I only lost 6 points. And based on Vincent Cockish, he believed if the CIE is under 26, it is a good finish. In this case, I only lost 6. Wow, I love it, 6. Beautiful. And 6 is because of occlusal relationship. We have only one incisor take out. So once you know the mechanic, and the diagnosis and treatment plan is right, and the clean check is reasonable, it will be easy for you to fix the mistake you find, the problem you have in the clinic. Let me give you one example. How would you fix a case like this? Easy, deep by. Did you see that deep by? Oh, I love it. Wow, this is a beautiful treatment. We saw this treatment over and over. 9 months in treatment is supposed to be like this. But unfortunately, in the clinic, it's like this. Wow! So, what is that happen? What's happening there? Supposed to be shadowed by, but the deep is still there and get even worse. Huge mistake in a clinic. And let me tell you, the one who make no mistake usually make nothing because they never try anything new. They just want to keep in their comfort zone. If you have a mistake, don't worry about it. Fix it. Find a way to fix it. So one more time, when you look at the computer, it's good on the computer screen, 9 months in treatment. But in reality, in the clinic, the debug gets worse. And you start to think, why would that happen? And the reason is because the aligner covered the occlusal surface. And the patient wear the occlusal, wear this aligner so well, they bite so hard, so they intrude the posterior. And it's hard to get the anterior intrusion if you intrude the posterior. You're supposed to intrude the anterior, but on the contrary, the patient intrude the posterior because that's the nature of this aligner, because aligner cover the occlusal surface, and the patient use chewy quite vigorously. They use the chewy to chew the posterior part. That's why you get the result like this. Don't worry, school can solve this problem. What I did is I put 4 mini screws like this, and look at that. Use this screw, I'll be able to intrude the incisor 4.5 millimeter anterior intrusion. Wow, that's a huge intrusion. And I do some frenectomy right here. And the way I did it is I wear this anterior elastic. If the Frenner, I can reposition the Frenner high. I can wear one. It's called flex. In the posterior, I also recheck the dentition backward because she has class 2 molar to start with. So I use this kangaroo. Sometimes I use chimma if the distance is too short. So how? Easy. First, you have this lingual cut. When you do this lingual cut, make sure you do a fray type. What I mean by fray type is you cut it wider outside and narrow inside. Otherwise, it will be difficult to hold this elastic. And have the patient preload this elastic. You have to cut it by yourself. Not by myself, by my assistant. Because the aligner company, they don't cut this for you. So you cut it by your assistant. All my assistants know how to cut it. It's easy. So when you cut it, and the patient preload this elastic, and wear this aligner, and wrap around this fox to the mini screw. And that produce, this wrap around elastic produce intrusive force by this mini screw and elastic to intrude. So easy. Every patient can do it. There's no problem to wear this one. And then you wear the class 2 elastic from posterior mini screw to the precision cut in the canine. So the aligner will cut this for you if you prescribe. And it is so easy to wear this one. And there are two ways to hook this elastic. If you have a high Fresnel, patient have high Fresnel, you wear one elastic. If you have low Fresnel, you can either cut the Fresnel, reposition it, or you can wear two. So you can stay away from this Fresnel easy. Hard tip. How to express tip by correction. Number one, overcorrection. Overcorrection. Number two, chewing. And number three, ask the patient to chew the front teeth. Number three, incisor screw. For me, these three, I want to combine these three. That will be easy. Good. So we know how to fix the problem. And the conclusion is, you might get a conclusion. Deep bite is hard for aligner. If deep bite is hard for aligner because they cover the posterior, then open bite must be easy for aligner. Well, theoretically, it is right. Open bite is easier. But my answer to this question is, it depends, period. It really depends. Some open bite may be very difficult for aligner to fix. Let me give you one example. How would you fix this huge open bite class 2 with TMJ problem? How? The patient has idiopathic resorption of the condyle head, one side. And then you might wonder, what was the occlusal relationship from to be related to TMJ? Is the occlusion related to TMJ? To find out the answer, I check how common was this condition report document study. And guess what? They were 84 study report for the past several decades, like this. And if you look at carefully, 16 studies talk about anterior open bite, which is 20%, with you have big overjet, which is class 2, most likely, is 17%. You put them together, anterior open bite and big overjet consists 36%, which is related to TMJ. Wow. So when you have anterior open bite and you have big overjet and you have the condyle head resorption, you better be careful. The resorption of the condyle is quite obvious right here. The left hand side is good, the right hand side has severe resorption. And what would you do? Oh, obviously, you don't want to put extra force to the condyle head. So if you wear the aligner and ask the patient to chew, you kind of increase the pressure to this condyle head, which you don't want it. You don't want to put an extra stress on the condyle head. And what would you do? How would you fix this one? Okay, let me just close. How would you fix this one? Oh, good. I think the best way would be just forget this case. Refer to somebody else. And I was lucky. My dear friend know how to fix this case. Because this is difficult. Think about it. How can you solve the problem? First, in order to release the pressure of the condyle head, we talk about open the condyle space. You don't want to press, you don't want to put a pressure on condyle head. And then you need, by intruding the posterior, and then you need to rotate the mandible forward, and you need open up the tongue space, and you need to change to nasal breathing. And none of that is easy to fix. Very difficult to fix. How? I don't want to treat the case like this. I don't want it. So I was lucky. Take a photo. Next time you have a case like it, make sure you know you don't want to treat this case. I'm serious. So I was lucky. I have a friend. His name is Domingo Martin. He told me, hey, Chris, I can fix all kinds of TMJ problems. So, well, that's good. So I referred this case to my friend, Domingo Martin. But unfortunately, this young lady insists to have Invisalign. And my friend Domingo, he didn't like Invisalign. So the patient returned to my office, and I have to fix myself. And let me ask you one question. Can you intrude the posterior without overloading this TMJ? Huh? Because when you wear the aligner, they intrude the posterior. And if they want to intrude the posterior, they have to put occlusal force. And they will put an extra stress on the condylar head. 9 months in treatment, we be able to intrude the upper posterior and rotate the mandible. Intrude by screw, not by aligner. That's the key. So I put outside and inside screw and wrap around this elastic, and with this mechanic, we be able to intrude upper posterior and rotate the mandible forward without putting extra pressure on the condylar head. 6 months in treatment. Wow, 9 months in treatment. Can you believe it? And what's the difference? The difference is if you use screw to intrude the posterior instead of aligner, you don't get overloaded on the TMJ, and that's exactly what we want. And screw can help you to execute this precise mechanic. Diagnosis, treatment plan is the key. If you don't know the diagnosis, how can you fix the case like this? You've got to make a lot of mistakes. To summarize what we talked so far, I want to keep it super simple. My preference in my clinic, I have a timetable like this. Aligner number 2, I bound the attachment. So aligner number 1 is just warm up. Warm up 1 week or 2, I bound the attachment. Aligner number 10, I prescribe the cutting and IPR, first IPR. Aligner 18, if I need a screw, I put a screw. I have a second IPR. The IPR, I don't want to spray the IPR all over the place. I want to group into 2 or 3 times. Should be okay. If you spray all over the place, it's just difficult to keep track of that patient. So just group into 2 or 3 times should be okay. Pounding for extraction case, always half pounding. I don't want a full pounding. Half pounding is easy to grab the motor. Digitalization, I want a sequential digitalization, which is 1 by 1. I don't want a group digitalization. Number 4, if I have a severe class 2 or class 3, do you know what I will treat? I don't want to treat it because they are very difficult to use the aligner at this stage. Maybe in the future when I grow up, I will challenge those severe cases. But right now, I want to stay in my comfort zone. And I strongly suggest you, if you are a beginner, do not try those severe class 2 or class 3. Those are difficult cases. Even for the seasoned professional, they are difficult. And what makes you think if you are a beginner, you can fix those difficult class 2 and class 3? All of the information can be found in this article. If you want to learn those materials, every single piece of the material I talk about today can be found right here. This is a beautiful publication. Or you can go to my YouTube to find out the detail. And I got a final thought. I think it will be beneficial for you if I give you an overall review. All the tips that I learned over the year, how to learn this aligner. And I hope with that overview, that will get your learning process, learning journey much, much smoother. First, I list 12 tips for aligner. Give yourself time and stay focused. You can learn anything, or you can learn how to use this aligner overnight. It's just not going to happen that way. Number 2, pre-aligner treatment for extrusion, space crossing, transposition, rotation. If you find it's beneficial, why not use it? Do not insist aligner only. Number 3, have a clear vision of tooth movement sequence. Of course, apply your mechanic knowledge. Know and master attachment design. And pushing is easy for aligner, pulling is hard. Number 7, sequential digitalization for class 2 or bimaster protrusion class 3. Anchoring. Always think about action and reaction. Newton's law number 3. Master your clean check with pre-clean check routine. What I mean by pre-clean check routine? Number 1, precise record. I prefer scan, strongly suggest. Reasonable treatment plan. Of course, if it's extraction case and you prescribe non-extraction, how can you finish that case? Overcorrection for rotation, root top, tip by, anti-tip. Always set a preference. That will make your life much, much easier. Tell the clinician, I want a sequential digitalization. I want an IPR at stage 10, 18, 26. I just consolidate. And if I want a non-extraction, I'm thinking about expansion and how much I want to expand, how much I want to digitize, how much I want IPR. Do I want to flare in the incisor? I put a question mark. Most patients, you don't need it. Number 10, use an intraoral scanner. Oh, important. Don't be afraid of IPR. Screw and elastic is not only for braces. It's also for alignment. When in doubt, my dear friend, this is the most important single message I like to get across to you. When in doubt, my dear friend, school. Thank you, my friend.